Hello and welcome to the last lecture for psychopharmacology. This is chapter 14 and we're going to talk about steroids and smart drugs. So in this last chapter, we're talking about enhancement of physical performance and enhancement of mental performance. So unlike a lot of the other drugs we talked about in this course, these are drugs used to enhance performance, not for pleasure generally. So that is a big difference. And there are plenty of legitimate and health-related reasons why you need drugs that enhance performance. One key area that we'll cover in this chapter are conditions where the person has age-related cognitive impairments. So as people get older, they're more likely to have Alzheimer's disease or mild cognitive impairment or frontotemporal dementia. And so medications can be useful in enhancing cognition. In previous chapters, we talked about attention deficit hyperactivity disorder, and that is another enhancement of cognition. We talked about that in the amphetamines chapter, so you can go back to that chapter and look at that. And then steroids are used for delayed puberty and wasting syndrome. So there's reasons why we would use steroids to enhance physical performance. So first we'll cover anabolic steroids, and then we'll get into the cognitive enhancers. So these are anabolic steroids are synthetic hormones related to the male hormone testosterone. And anabolic steroids have muscle building and masculinizing effects. So the muscle building effects are anabolic, the masculinizing effects are androgenic. And so when you take steroids, it will increase the available protein in muscle cells, making more muscle grow. So this, if you have more muscle growing, this will enhance athletic performance and muscle strength and appearance and lead to more muscles. There are legitimate medical uses. So someone might have an injury and they need to repair muscle. You might have a short duration course of treatment with steroids, but they are also misused, and misused most commonly among athletes where the sport requires muscle mass. So things like football, baseball, bodybuilding, those kinds of sports, you might see a lot of misuse of these drugs. So if you look at the epidemiology, the World Anti-Doping Agency tests athletes all the time, and those high-level athletes, back in 2004, there was data that about 1/3 of athletes failed drug tests involving steroids. There's more and more testing of athletes. It's more and more difficult to find an athlete that's misusing substances because there is so much testing now, and it's become cheaper to test. So I used to drug test in the lab all the time, and you could give a panel of all kinds of drugs that possibly could be in someone's urine, and those tests only cost a couple of dollars to run. So as the costs have come down, the amount of testing has gone up. The most common misused substances for athletes are testosterone and nandrolone. Past use of steroids is still not very common in the general population. It's also not that common in athletes because they're tested so much. It's difficult to get away with it, so to speak, without being caught. And there's significant concerns about your future academic, your future athletic performance if you are shown to be misusing these substances. So anabolic steroids are going to act like testosterone in the body. It can lead to dramatic physical changes with repeated dosing. The dosing that athletes would use that misuse these substances are sometimes 100 times the medically recommended doses. And so individuals would use them for weeks on end, either oral or injection, and they will report things like reduced fatigue so they can work out longer, lift more weight without getting too tired. They might feel a bit of mild euphoria, but that's obviously not the reason they're using them. Muscles recover much more quickly, so you can then do another workout, and muscle will grow, and you'll also see increased red blood cells and bone growth. Now, they're not innocuous because there are plenty of side effects. So the first thing that is concerning is that these high levels of steroids lead to increased aggression, and irritability, hostility. Sometimes that's called roid rage, where you just have a person easily provoked, easily willing to get into altercations like a fist fight or something. And then there are the other problems that are concerning to the well-being of the person. So for example, it could lead to stunted growth due to premature bone fusion. It could lead to early sexual development and acne in males, and development of male traits like deep voice or facial hair in females. In males, the testicles can shrink, the sperm count decreases, and breast tissue can enlarge. So these are all things that are not easily fixed, and certainly very aversive. When you look at tolerance and withdrawal, there isn't much research on tolerance and withdrawal, but you do know that there's some tolerance that may develop, but the chronic use can produce some dependence and withdrawal symptoms if you suddenly stop taking them. The typical things are the depression, fatigue, insomnia, loss of appetite, restlessness, and loss of sex drive are sort of the prototypical things that are reported. So pharmacokinetics, a little bit about steroids, that you have oral injection or injection administration. Onset occurs over hours. Users are probably not going to notice anything until they've been using chronically for a while, many weeks. Oral testosterone has no effects as it is immediately metabolized by the liver, so the synthetic anabolic steroids bypass immediate liver metabolism so it can reach the site of action. You can determine that someone has been using steroids because steroids are excreted in urine. And so it actually lasts a while in the body. So you can detect this in urine for up to 14 days. And some much, much longer, and up to a year. Okay, so that was a little bit about steroids. Now let's switch over to enhancement of cognition. Smart drugs as a category. So these are pharmaceutical drugs, supplements, nutraceuticals, and functional foods that enhance cognition, how you think. They are sometimes also called nootropics. And you probably remember from different parts of this course that stimulants, cocaine, nicotine, amphetamine, caffeine even, can enhance cognitive performance. They can mitigate fatigue. We remember that even from the caffeine chapter, and we think about caffeine as not being a really super powerful psychoactive drug. So where would you use these smart drugs? Well, the main area is for dementia syndromes. So as someone gets older, and if they succumb to a dementia type disease process like Alzheimer's disease, there's going to be significant loss of global cognitive ability. And these smart drugs can help treat the symptoms. I participated in a lot of clinical trials. I worked for a neurologist, and so it was really interesting to sort of learn about this topic area, because what I really took away from doing research in this area and reading papers in this area is that what you have with aging is a normal linear decline in cognitive function that occurs as someone is aging. But what happens with dementia is you kind of like drop off the cliff fairly quickly once the disease process starts taking hold. Now, these smart drugs are just going to keep the person from dropping off the cliff. They don't really enhance performance above the person's baseline. They're just preventing that deep drop that would occur with the disease process left untouched. So, grandma who's having memory problems isn't suddenly going to turn into, you as a young genius. Grandma will just be less confused about where she put her keys, and she'll maybe remember to turn off the stove when she is finished making dinner, things like that. Things that are helpful for safety and well-being and quality of life. So there are different forms of dementia. Alzheimer's disease is the most common, and actually there are not that many approved FDA drugs that really can help with dementia, which is really rather surprising considering how we are living longer. And so more people develop dementia syndromes, and more people will need help with medications from this category. In all cases, most of these drugs, 4 of them, inhibit the breakdown of acetylcholine. So they're increasing acetylcholine levels, and that's what's helping with cognition. And then one of the other drugs in this category antagonizes NMDA, glutamate receptors, decreasing glutamate, which is harmful. So just a brief history about where these drugs have come from, the SMART drugs. So Alzheimer's disease was first described by Dr. Alzheimer in 1911. And what has changed since that time? Well, obviously a century has passed, and lifespan has increased really quite dramatically over time, so that dementias are much more common. So people didn't live as long as we do now back in 1911. So you just didn't see as many people develop dementia 100 years ago, say, compared to today. The first SMART drug was actually a relatively recent invention. 1993, the first drug was approved by the FDA, Cognex, and others were approved in the 90s. This really means more drugs in this category. So a lot of the drugs that are on the market have significant side effects, and older people don't tolerate them all that well. And given that more and more people are living longer, we need more options. So looking a little bit about cognitive impairment, cognitive impairment or dementia is present in 1 in 5 individuals 65 and older. 20% of people who are 65 and older have some sort of cognitive impairment. Think about that, 1 in 5. That's a lot of people. So there are older people who are experiencing no cognition impairments. Maybe they have a little bit slower processing of information, but we have a lot of individuals who could use some help with cognition. 50% of the dementias are Alzheimer's disease, so problems with memory, but not all of them. So sometimes dementia is caused by stroke. That's caused by stroke, the blood clot in the brain. That is called vascular dementia. Then there's frontal temporal dementia, which is the dementia I worked on. It's very interesting. Frontal temporal dementia is more likely to occur in younger people, even younger than 65, when it has an onset. It is primarily dementia that causes problems in the prefrontal cortex, frontal cortex of the brain, hence the name frontal temporal. The frontal part of the brain is the impulse control of the brain. So these individuals have really tough time having control over their impulses. If it moves into the temporal lobes, which a lot of times it does move into the temporal lobes, or it may start in the temporal lobes and they have trouble with speech. So they might have aphasia. Over time, all people tend to eventually have damage in both the frontal and temporal lobes. So eventually everybody who has this diagnosis has both aphasia, language problems, and problems with impulse control. It makes it difficult to care for these individuals because if you remember the classic case of Phineas Gage, where Phineas Gage had a rod in his frontal cortex and he wasn't Gage anymore, his personality changed, he wasn't really nice anymore. A lot of times that's what happens with FTD patients. It's hard to feel like that person is the same person when their personality shifts like that. Also, Parkinson's disease is another big category of individuals who have a degenerative dementia. And a lot of times people think of Parkinson's disease as having the motor control problems, which is definitely a primary symptom. But you also see cognition problems that develop with Parkinson's disease as well. So Alzheimer's disease, as someone lives longer, they're more likely to be diagnosed with some form of dementia. Alzheimer's disease is a great example of this. So between the ages of 65 and 69, only about 1% of individuals will be diagnosed with Alzheimer's disease at that age. But if you're lucky enough to live to 95 or older, 50% are likely to be diagnosed with Alzheimer's disease. So the prevalence doubles every 5 years after age 65. So the longer you live, the more likely you're going to want a medication that helps you with cognition. So if you give smart drugs to individuals, the first thing you'll notice is you won't really notice anything. No changes are immediately observable. Earliest side effects are the side effects. So nausea, abdominal cramps, vomiting, diarrhea, lots of unpleasant side effects, loss of appetite, sometimes aggression. But after several months of treatment, then you start to see changes in cerebral blood flow. And that's when cognition seems to be, stabilizing. You don't see continual declines. They might actually look a little bit better. And by about a year of treatment, then you start to see clear benefits where the mental decline is not declining further, and brain atrophy, if you are scanning them yearly, which if usually at that point, a person is going to a neurologist once a year to get an MRI scan, take a look at their brain and see where the atrophy is happening. The atrophy tends to be stable. It does seem to protect against neuronal loss. And the important thing is it keeps the patient, in many cases, at home. So they don't need to go into a long-term care facility or a nursing home or something like that. They can continue to live a life that is similar to what they have lived before. So it is improving quality of life. About half of patients experience good benefits. The key thing, if you ever talk to an older person who's starting to have memory problems, is start the treatment as early as possible. Because once the brain atrophy occurs, the brain matter is gone. So if you start to lose brain matter, there's not much that's going to happen. You can't grow new brain matter once you're over 65, right? So the earlier you start these medications, even when it looks like, oh, maybe they're having a tiny bit of memory problems, but it doesn't look that bad, that's the time you want to start it. These drugs are most effective when the person has mild cognitive impairment. And so that's why you sort of see mixed results from patients. If you wait too long to intervene, then the drugs have less to work with in the brain. Also, you have to be careful. There are side effects of these drugs. Liver toxicity is one of these things that has to be monitored closely. When you look at tolerance and withdrawal, tolerance to the effectiveness is not a major concern. These are drugs that, as long as the patient can tolerate the medication, they may be on them until the end of their life as much as possible to maintain cognition. There may be some tolerance to the side effects. So like if the person in the first months of treatment are experiencing a lot of gastrointestinal distress, like nausea, diarrhea, hopefully that goes away. And there are very few withdrawal symptoms if you just stop the medication for whatever reason. So pharmacology, these are acetylcholinesterase inhibitors that are improving memory by increasing the availability in the brain of acetylcholine. And they inhibit the action of acetylcholine enzyme, which normally metabolizes acetylcholine in the synapse. So if you think back to the nicotine chapter, you know that nicotine has the actions on acetylcholine, and that is also why nicotine enhances cognition. So it kind of bring it full circle, right? Remind you of some things that we talked about quite a few weeks ago. The NMDA receptor antagonist drugs antagonize glutamate. So they have a different mechanism, and the excess glutamate is believed to damage neurons. So in some cases, it's kind of trial and error which one you pick for an individual. There aren't that many drugs on the market, and if one person has serious side effects for one, you might want to switch them. The acetylcholinesterase inhibitors and the NMDA receptor antagonists act quite slowly. They have long half-lives if you take it in a pill form, oral administration. Steady blood levels are achieved within 15 days of daily use. So, if you take Aricept, for example, for 15 days, you'll start to see it. They readily cross the blood-brain barrier because it needs to get into the brain. And slow acting drugs. So as we are getting older and we have only some drugs that help with dementia, prevention of dementia in older people is really something that is of great interest. And we do know from research that environmental factors are shown to be associated with reduced risk of developing Alzheimer's disease and other dementias, like vascular dementia, right? Vascular health, overall vascular health will be important for health in your brain, of the vessels in your brain. So what do we know? Well, it's all the things you probably already realize. If you want to stay healthy for longer and live healthier, you want to exercise every single day. It's really good for your brain. You want to eat a healthy diet. You want to engage in a lot of cognitive activity. Using your brain is the best way to protect your brain. So what you're doing right now, learning material that's new and challenging and taking quizzes and all those sorts of things, you should be doing the exact same thing when you're over your 65th birthday. You want to be doing the same thing. Pushing your brain to do new things is a great way to protect your brain. Educational attainment is one of those things that we know is correlated with health in old age. So the more you push your brain to do new things, the healthier you will be. And so, all these things are things that you have control over. And so I think that's sort of helpful to think about. It's not that genetics doesn't matter. It does. Some of these dementias, you may be genetically predisposed to develop them, but there are a lot of things under your control in your environment that you can do to make sure you have a long life and a healthy life. And that's the end of that lecture. Thanks, everyone.